Welcome back to Audioboards. Today we are breaking down one of the most high-stakes environments you will encounter as an internal medicine resident, running a code blue. Using standard ACLS guidelines, we are going to dissect the code into three manageable phases: early, middle, and late. Let's dive straight in. Phase 1. The early phase: arrival, command, and setup. When that pager or overhead goes off, your adrenaline is going to spike. The most critical first step before you even cross the threshold of the room is to stay calm and check your own pulse. Remember, you are walking into that room to provide structure, not to add to the chaos. As soon as you cross the threshold, you need to identify yourself immediately. Step up, stand exactly where you can be seen and heard by the entire room, and state clearly, "I am Dr. ABC, I am the code leader." From that second on, don't try to be the expert at everything. Your job is to command, not to perform procedures. Appoint specific people to specific tasks immediately to establish role delegation and logistics. First, look at a team member and order a code status check. Assign them to check the EMR chart immediately because you need to ensure you are not running an ACLS protocol on a DNR/DNI patient. Next, establish your compressions lineup. Delegate one person to line up a queue of compressors right away so people can rotate smoothly every 2 minutes without a drop in CPR quality. Simultaneously, get your equipment deployment moving. Have the team get the backboard under the patient immediately, pull over the crash cart, and position a step stool so your compressors have optimal leverage. Finally, tackle monitor placement. Explicitly request the defibrillator pads to be placed on the patient immediately so you are ready to analyze and shock without any delay. Phase 2. The middle phase, the algorithm and the thinking process. Now we move into the middle phase, which is the structural cycle of the code. Once the chaos settles, Code Blue becomes a continuous, rhythmic 2-minute loop of high-quality CPR, rhythm assessment, and targeted drug delivery. According to the AHA guidelines, perfection in your CPR and airway metrics is completely non-negotiable. For rate and depth, make sure your compressors are pushing at a rate of 100 to 120 beats per minute. Think to the beat of Staying Alive, and at a depth of 2 to 2.4 inches, always allowing for complete chest recoil. At the head of the bed, you need to avoid overventilation. Keep ventilation strictly at 1 breath every 6 seconds, which is 10 breaths per minute. Overventilating increases intrathoracic pressure, which decreases venous return and completely tanks your cardiac output. Keep an eye on your objective feedback metrics too. If you have waveform capnography and the ETCO2 less than 10 millimeters of mercury, your chest compressions are suboptimal, so use that data to optimize your compressor's technique. If the patient has an arterial line in place and you notice the diastolic blood pressure is less than 20 millimeters of mercury, that is your signal that CPR quality needs immediate improvement. Every 2 minutes, you are going to pause compressions for no more than 10 seconds to check the rhythm. As the leader, talk out loud through your thinking process so the entire room stays on the same page. Your brain will follow one of two pathways. Route A: shockable rhythms, VF/pulseless VT. If the monitor shows ventricular fibrillation or pulseless ventricular tachycardia, you shock immediately. Deliver biphasic energy at 120 to 200 joules, or monophasic at 360 joules. The second the shock is delivered, resume chest compressions immediately. Do not pause to check a pulse or a rhythm until that next 2-minute cycle is completely finished. For antiarrhythmics in refractory VF or PVT, incorporate amiodarone, giving a 300 mg bolus for the first dose, followed by a 150 mg second dose, or use lidocaine at 1 to 1.5 mg per kilogram for the first dose and 0.5 to 0.75 mg per kilogram for the second dose. Route B: non-shockable rhythms, PEA/asystole. If the rhythm is non-shockable, your first job is to verify asystole. Never shock asystole. Always check your lead placement and confirm true asystole in at least 2 separate leads to ensure it isn't actually coarse VF masquerading as a flat line. You can even increase the gain on the monitor to differentiate the two. For drug therapy here, give epinephrine 1 mg IV or IO every 3 to 5 minutes as soon as vascular access is established. This is also where you really shine as an internal medicine resident, diagnosing the 5 H's and 5 T's. While the team pumps the chest, go through the reversible causes systematically out loud. The 5 H's: hypovolemia, hypoxia, hydrogen ion acidosis, hypo or hyperkalemia, and hypothermia. The 5 T's: toxins, cardiac tamponade, tension pneumothorax. And remember, if you suspect a tension pneumothorax, do not wait for a chest X-ray, needle decompress immediately, pulmonary thrombosis or PE, and coronary thrombosis or MI. Phase 3, the late phase, ROSC or termination. Eventually, you will reach the late phase. You've run the loops, managed the room, and reached a critical transition point. If return of spontaneous circulation, or ROSC, is achieved, you pivot immediately to post-cardiac arrest care. Secure the airway, stabilize the blood pressure with vasopressor infusions, check a stat arterial blood gas and basic labs, order a portable chest X-ray, and immediately notify the ICU team and your attending physician. On the other hand, if the patient remains pulseless after several rounds of high-quality code management and you've exhausted your reversible causes, it may be time to transition to a discussion about terminating efforts. Pause the room, ensure crowd control, and ask out loud, does anyone have any other ideas, history, or suggestions before we consider stopping? This invites open communication and ensures clinical safety and collective alignment before making a definitive call. Once the code is concluded, regardless of the outcome, always debrief with your team. Take 5 minutes to review what went well, identify any logistical bottlenecks on the floor, support the nursing staff, and make sure the family and emergency contacts are notified compassionately and clearly. That wraps up this episode. Remember, step up, delegate early, talk out loud through the algorithm, and keep your chest compressions high quality. See you in the next episode. Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board-certified healthcare provider for any medical concern.